WHO Ethiopia country office. And for this particular session, I'm going to be the moderator for the next 1 hour, 20 minutes. Right. This morning's section, we are looking at governance arrangement for public financing of private sector engagement in mixed health systems of LMIS. You're all welcome to this session. Private sector engagement is meaningful inclusion of private providers for service delivery in mixed health systems. Private sector engagement requires that government focus on governance of the whole health system, both private and public, so as to ensure quality of care and financial protection for patients, irrespective of where they seek care. It requires that the private sector aligns with public sector health goals and commits to working to support the government agenda. This session for today will reflect specifically on the governance arrangements that help and hinder collaboration across a range of financing arrangements. We have in store for you 3 rapid fire presentations that will pretty much look at arrangements and how they operate in India under the National Health Insurance coverage. This will be followed by a moderated question and answers session with the presenters, as well as reflections from our discussants who provide their thoughts on similar experience in low to medium income countries. To start the discussion, I would like first and foremost to invite my colleague, Dr. Grace Achunugra, Technical Officer, Health Financing, WHO India, to talk us through the framework and set the context relating to public financing levers as a governance tool to organize PPE. So without much further ado, I hand over to Grace for the framing. Grace, over to you.
Okay. Am I audible?
Very much so.
Okay, good morning to all in Kigali. Good afternoon to those that are in India and wherever. Thank you for joining us. Mine is pretty simple to set the context for the 3 presentations and hopefully generate some discussion on the issue. We do know that in the countdown to the 2030 agenda, many countries are off track for most of the SDGs, particularly the health sector SDG. And so while there's been concerted calls for greater public engagement of the private sector, I think in the last few years, innovation about how to go about this, I think, is a bit limited. And with the current geopolitical climate, where we are seeing a lot of shrinking space with the donor funding, for most low-middle income countries, it means that conducting big bang reforms will be a bit difficult given the shrinking fiscal space. So what do countries do? In order to improve service availability, improve financial protection, the general recourse is for the public to engage better with the private sector. We do know that while the stewardship function lies with the governments, the regulatory mechanisms, enforcement mechanisms tend to be weak, but they are overseeing a mixed service provision landscape. And for most of the low-middle income countries, in some cases, up to 70% of the service provision is through the private sector, who are setting their own prices largely. And so that again now affects health expenditure. It causes spiraling health expenditure, causes increase in out-of-pocket expenditure and financial hardship. It's very difficult to account for quality of care since they are poorly regulated, but also accountability in terms of performance against UHC goals is limited. So when we look at WHO's health systems framework, we see that, yes, we have enabling functions around financing, around stewardship, around service provision, but then it's also around the resource generation for medicines and human resources. These are not mutually exclusive functions. And so with this session, we are hoping to see how the nexus between public financing can be leveraged to strengthen governance arrangements without necessarily upending the system that much in order to achieve incremental steps, incremental improvements in terms of financial protection, quality of care. So with the two case studies from India, they are largely within the purview of the largest public health insurance scheme in the world, that is the Ayushman Bharat, PMJ. And we'll be looking at the implementation models that the government uses to contract private insurers to ensure that there is extended service coverage, leveraging their expertise. We shall also look at the factors that are affecting the private sector provider engagement within the health insurance scheme and what the government has done towards that. And then we shall look from one of our very own on African continent, the case study from Uganda, which will be presented by Christabel, and hopefully we can glean some lessons from there and generate some discussion. Thank you, Kingsley.
Thank you very much, Grace, for giving us the framing for the conversation for the next 1 hour. So to start our session, our first presentation is going to be delivered by Malik Chosky. I don't know whether I got the name right, the pronunciation right. So Malik is actually Deputy Country Director, Access Health International in India, and he'll be highlighting some of the key determinants of private sector engagement under the PMJ scheme in India. Malik, over to you.
Thank you very much, Brandon. Can you see my slides, please?
Yes, if you can put it in presentation mode.
Yeah. So what we did, as Grace said, for India, it's the biggest kind of publicly financed health insurance scheme, Pradhan Mantri Jan Arogya Yojana. And it caters to the secondary and tertiary care needs of its population below poverty line. And that was one way where we at a government of India level try to enhance access to secondary and tertiary care services to people. In India, it's important to notice that health is a state subject, a state or province as people use in kind of geopolitical parlance. And we have 29 states in India through which this PMJ is kind of implemented. And the way that interaction happens has got effect on the way healthcare delivery happens. And this is what we try to understand. What are the determinants of private sector engagement and empanelment in PMJ? So, as said, it was the biggest publicly funded insurance scheme, centrally guided, implemented through states. And because our 70% healthcare expenditure happens from private sector, it was important for us to understand what are the factors that kind of affect their behavior. And despite of involvement in provision care, there are still kind of inherent kind of inhibition from private sector of not to empanel them. So we wanted to understand that if we want to enhance empanelment of this.
Malik, you're muted.
Host is muting me. So they have unmuted me now. Can you hear me?
Yes.
Hello?
Yes, we can hear you now. We can hear you.
Am I audible?
Yes, please go ahead. Yeah.
Thank you. So, and with that objective, we wanted to elicit motivation for hospital to get empaneled. And there are a lot of chunk of hospital during COVID period who became part of this PMG implementation program, but they got de-empaneled later on. And there were a group of hospital who never became part of this ecosystem. So we wanted to understand if they are part of ecosystem, if they left that ecosystem, what were the reason behind that? If they are part of ecosystem and still they're inactive, what are the reasons behind that? And what are the reasons which kind of impacts their enrollment, and into day-to-day operations, what are the factors that can be improved to enhance their day-to-day performance? So as an approach and methodology, we wanted to, this was a qualitative study. We identified 4 states in which we did this study. And the state selection was, there are different models of implementation at state level. One where an office is set up, we'll call a trust model. Then there was a model where an office will kind of contract in a third party administrator. So we call it hybrid model. And there was an insurance model where everything was outsourced to an insurance agency. So we identified kind of 4 states with this kind of institutional structure, conducted 48 key informant interviews, primarily with state health agency, insurance company, TPAs, private hospitals, and representatives. And in this process, we kind of try to understand what are the incentive structure, provide mechanism, illegal issues, institutional issues, technological issues, which kind of drives their empanelment or kind of their service provision as part of PMJ. And what we found that a lot many hospitals became inactive. During COVID period, there was mandated by government to kind of involve them in delivery of care. And post-COVID, lot many hospital got kind of de-empaneled or they stopped providing services. And also the behavior of backlog of COVID inhibited private sector to further kind of get involved into delivery of care. Also, many private sector hospitals wanted to get involved only in kind of high value kind of procedures where there is the delta is good, there is a lot of profit making, and that resulted into kind of selective coverage as far as hospitals are concerned. Hospitals only kind of, even if they've got 10 specialty, they would only get enrolled for 5 specialties or 7 specialties, which are profiteering for themselves. And the delay in payments was kind of affecting their viability. So they thought of not continuing in PMJ. And PMJ, wherever there is a pre-authorization process, a third party involved or insurance company involved, I think so the delay in pre-authorizations or query did affect the way hospital process were undertaken. And there are also positive in terms that there were many hospitals who wanted to provide care with a societal perspective, and henceforth they became part of the ecosystem and utilized. So in certain states, the bed occupancy rate was around 40%. They wanted to increase their occupancy rate, so they became part of this PMJ structure to increase occupancy rate and be competitive. And decisions are generally kind of influenced by the ownership type, bed capacity, occupancy rate, as I said earlier. In particular state like Jammu and Kashmir, we also saw there is a humongous increase of hospital empanelment from 53 to 93. And that was primarily because, as Grace mentioned, social development goals. I think so. The state government kind of agreed to provide universal health coverage, and that resulted into increase in hospital empanelment over a period of time. And because it was a government driven kind of government driven approach, I think so the institutional engagement between the hospital and the state health agency became very, very important, and they focused a lot, which resulted into kind of in Jammu and Kashmir a smooth and hassle-free communication between multiple parties. And when that communication was not good, like in the state of Maharashtra or Madhya Pradesh, that affected the motivation of hospital to be engaged in delivery of care. And as I said, that once the communication gap happens, obviously the grievances that arise does not get addressed, and that was one of the reasons that lot many hospital did try to opt out, leading to distrust in the scheme. State did innovation, Kerala, to address that. They identified district level kind of coordinators who started working with both beneficiaries, or I would say the consumer as well as providers, to see that ecosystem gets strengthened. But again, at a provider perspective, the financial viability. PMJ is a reimbursement mechanism where the benefit package rates are defined by publicly financed institution, and lot many private facility did not seem them to be viable. Even in kind of Maharashtra, where trust-based hospitals are those hospitals which are supposed to be not profit-orienting, but for them also viability of package rates reimbursement was very less. And in certain cases, when you have got a patient with multiple morbidity, the limited package selection or the possibility of moving from one package to another package was a deterrent, resulting into limited optimal patient care. And all those factors kind of affected the way hospital perceived their engagement with health system. There were also some kind of positive and negative legal and technological issues. While, as I said, the private sector involvement was primarily through during COVID using Disaster Management Act, which enforced or mandated each and every private sector entity to be part of it. Kerala, and Maharashtra also kind of the state, as I said, health is a state subject. So state can kind of improvise or kind of once the package rates are defined by the federal government, if there is some enhancement required or enhancement based on the state needs, the state can do it. So Jammu and Kashmir, Kerala, Maharashtra did venture into that consultation with private sector to change package rates. Kerala also introduced legislation to enforce the hospital staff get minimal wages. A lot of money that got kind of mobilized at a public health institute were used to give incentives to motivate private sector. But payment challenges always were a concerns which affected the participation. And payment, not in terms of receiving, but it also in terms of there is a transaction management system that is being used. So transaction management systems, responsiveness in terms of timeliness, the time taken to upload document, the time taken to the size of document, those kind of procedural thing also affected in the way private sector, and that deterred the private sector involvement in participation of PMJ. Providers did raise some concern about patients' rights because in PMJ, yeah, there is biometrics and there are identification required, and lot many hospitals did raise concern about their kind of inability to protect the data once collected from the patient. And all this issue kind of led us to some areas that we can think about can enhance the role of PMJ. Categorize a structural issue where state flexibility should have enhanced flexibility to negotiate the package rates. They can implement dynamic package rates to see that based on the morbidity and the need, if there is a result, there is a need to kind of look at the reimbursement prices. And it is important for private sector and association to be involved in creating package rates. The transaction management system, as I said, should be simplified, and especially when the hospital size becomes smaller, it's important for them to understand and becomes easy for them to use TMS. And timely payments is something that's non-negotiable. Enhanced monitoring to prevent fraud and kind of under the table dealing. Claim rejection redressal. So if there are claims being redressed, I think so there needs to be a mechanism where they need to know the reason why the claims were rejected, and we need to strengthen those things. And all those things can only happen when the stewardship roles of government become strengthened in terms of creating referral pathways, quality audits, as I said, public sector efficiency incentives, and a stronger contracting and regulatory capacity at a stewardship level. Thank you.
Thank you very much. Thank you very much, Malik. In terms of the key determinants of private sector engagement, I picked about 4 components. You talked about structural issues, enabling institutional architecture, an introduction of digitization, more especially into the claims management, and then monitoring and strengthening stewardship. Thank you very much for sharing with us. We'll move on to the next presentation, which pretty much will be looking at the comparative performance of government agencies versus private administrative intermediaries implementing the PMJ scheme in India. And to help us with this is Professor Keya Melo Fetando, who is Associate Professor of Public Health from Goa Institute of Management, India. Prof, take it from here.
Thanks, Brendan, and good morning to everyone in the room. My apologies that I can't be there in person to make this presentation. So what I'm going to present is, the comparative performance of private insurance companies with public trusts with regards to the same scheme that my colleague Maulik just mentioned, the PMJ scheme. So this is a different kind of engagement. Maulik talked about engagement with providers. This is an engagement that governments do for the purchasing functions. So we look at what are the purchasing functions for which they engage with private insurance companies and what kind of implications this has. I'll just pause to make sure that I'm audible. I hope everyone can hear me. Can someone confirm? Yeah. All right. Okay. Thanks.
Yes, we
All
can
right,
hear you.
Thank you. So states have, if you caught Maulik also mentioned this, states can either directly, there are two essential models and a hybrid, but I'll just talk about the main two models, which are they either can purchase services directly from empaneled providers through a government entity or a public entity, which is called the State Health Authority. And this is the trust model. Or they can contract private insurance companies as intermediaries to contract services from providers. So there are these two models. So you have the trust model in which they do it directly, or the insurance model where they contract with insurance companies. And we did this study because the National Health Authority, which is the central agency responsible for implementing the scheme, was keen to really know how these two ways of purchasing really compared with each other in terms of performance. They wanted this to inform their further decisions, but more importantly, they were concerned because there had been previous instances of misaligned incentives, of course, of the public entity and private agencies, which would affect or they thought might affect system performance goals. The literature also shows us these instances of misaligned objectives. We've seen in the past with earlier schemes that, private insurance companies might be incentivized to reject large numbers of claims because this helps them maximize their profits. So, reject a large number of claims and have larger administrative fees to retain. So this, of course, goes against the objective of the public sector to improve access and expand access to the scheme. The other thing is where contractual arrangements were available, there was limited enforcement, limited oversight, and therefore limited stewardship overall of these contractual arrangements between the public and the private entities. On the other hand, if the government depended completely on its public trusts, that was not all a rosy picture there as well, because in many cases, there was a lack of the required expertise within the trusts to do some of these purchasing functions, their inability to really control certain market failures like supply-induced demand, or also to absorb financial risk. And so for this reason, both models do become necessary. We also see instances of contracting of private intermediaries in other countries. And there as well, we see that the governance and the contracting arrangements are really key to whether these experiments can work or not. And we know that contracting private agencies is really done when there is a capacity constraint in the public sector. And so therefore, states are given this flexibility, but what we sought to look at is how does the performance compare? Now, we compared performance on specific things which have to do with the utilization of the scheme and claim management. I'll come to why we selected these particular functions in a bit when I come to the methodology and the framework. But while looking at the performance outputs, we also try to look at what were the governance arrangements, specifically contract terms, that really could explain these observations on performance. And so that's what I'll sort of highlight today just briefly in the limited time we have, which is how did performance on these two parameters compare, and what were the governance arrangements really that informed these observations. So we use the strategic purchasing framework. I'm sure most of you are familiar with this. And So we broke down the purchasing functions by what health services, which is benefit package design, from whom to purchase, which is the empanelment function, how to purchase, which is payment mechanisms, but also claim management and financial risk management. And what we see is that in the case of PMJ, even where insurance companies are contracted, not all purchasing functions are contracted to insurance companies. So their functions are limited to managing claims and managing financial risk, whereas the public entity still retains the other functions. So benefit package design, provider empanelment, provider payment methods, these are all decisions that are made by the public entities. So we compared, therefore, claim management, which is where the insurance companies' functions really kick in. And what we see is that, in terms of our data, so this, we selected 6 states in consultation with the National Health Authority, 3 with either model. We used a comparative case study design, and we used both quantitative and qualitative sources of data. Our quantitative data was from the IT system that processes claims, the transaction management system. We collected data on the human resource workforce in all these states, their functions, how much they process in a given amount of time, etc. And we also, our qualitative data sources was of course, a review of documents, both scheme guidelines, but also contracts, and key informant interviews with both the trusts, insurance companies, empaneled hospitals, and their associated entities. So we first examined the contracts and the key features of the contract with the insurance company. The first is, how are they selected? Now, insurance companies bid for contracts, as is most often the case, and they bid with a per family rate at which they will cover people under the scheme. We found that, it's usually, again, I understand the, mostly the case in India and elsewhere as well, but the lowest bid usually wins. There is, of course, a standard technical criteria, but it's very limited, it's very basic, and financially, whoever bids the lowest usually wins the contract. The payment terms were important. So how much do insurance companies make? They are allowed to retain an administrative fee. Now, this administrative fee is linked to the claims ratio that the scheme reports at the end of the year. A claims ratio of less than 60%, and a claims ratio, just to, if anyone's unfamiliar, it's the total payout upon the total premium. So if that's less than 60%, then they retain about 10%. If that's between 60 to 70%, they retain 12%, and they retain 15% for a claims ratio that's higher. But also insurance companies are protected. If their claims ratios are really high, like above 120%, then the public entity shares some of the risk. So there is that protection as well for insurance companies because of the nature of this program. And the third thing about the contracts is performance appraisal. So insurance companies are meant to report certain performance indicators, such as their turnaround times, the number of audits they do, things like that, which are reported to the public entity. Now, I'll come back to how these contract terms relate to the performance that we see in the subsequent slides. I'll come back to this, but what was the performance like on utilization? Now, overall, we found that the hospitalization rates, and we're looking at hospitalization rates because that's primarily what this scheme is for. With the exception of a few states, mostly the scheme only covers hospitalization and some daycare procedures. But in this data, we've looked specifically at hospitalization, and we see that the rates are comparable between insurance and the trust states. Individual hospitalization rates also have been compared for your reference, but I won't get into this for the paucity of time. We then looked at claim rejections. Now, if you remember, I mentioned in the literature, we've seen high rejections by insurance companies in the past. But here we find that the claim rejection rate is actually lower in the insurance model as compared to the trust model. So we see 2.3% in insurance states compared to 4.8% in trust states. Now, there are exceptions, and I just want to highlight the exception of Jammu and Kashmir, because that relates a lot to governance, which is what we're talking about today. So the rejection rates, and we tried to look at, what were the reasons for high claim rejections in Jammu and Kashmir. And we saw that a lot of the claim rejections really had to do with the fact that public hospitals had their claims being rejected because they were unable to process claims on time. They didn't have the capacity to submit the correct documentation. And so a lot of their claims were getting rejected. And in this instance, and there were lots of claims that were also wrongfully rejected. So what we observed is that the state health agency intervened to examine these rejections and to look at whether they were legitimate or not. And they found that there were a lot of wrongfully rejected claims, which they then had to revoke. Now they revoked about 10,000 claims, and wrongful rejections also draws a penalty from insurance companies, and this was also levied. So this was really an example of how the oversight of the state health agency was really important in bringing down a high rejection rate by an insurance company. However, to remind you, overall, we do see lower rejection rates in insurance states, and I'll come to why that was the case. The state also revised guidelines to make it easier for public hospitals to be able to adhere to these payment timelines. So they increased the time that was given to public hospitals to submit the requisite documentation. We then looked at the claim management efficiency, and what we saw is that despite a smaller workforce, the insurance companies were able to process a higher overall volume of claims. So overall, the number of claims they processed was higher. And an important parameter, as Maulik also mentioned, is the time, the turnaround time. How fast do hospitals get their payments? And what we saw is that the insurance states were processing claims faster. So the turnaround time was about 14 days, which is within the 15-day limit, which is the prescribed sort of time frame. Whereas the insurance companies were taking about 48 days, which is much higher than what is required. So we do see that insurance companies show higher efficiency in terms of the turnaround times. But when we spoke to providers in trust states, they weren't unhappy with the turnaround times, in our particular study, because they did have an assurance of payments. This was at that point of time. Things do change from one period of time to another, depending on who's the entity in which state. But this was what we found at that time. So like I said, I'd come back, to the contract terms and how some of these observations link. So the first thing was, the selection. Now, what we also looked at was what were the claims ratios that were being reported in our study. We saw that we were seeing claims ratios of above 100% in 2 out of the 3 insurance states. Now, when claims ratios are that high, we know that the insurance company is not retaining anything as administrative fee. So how is this tenable for them? Like, why are they okay with such high claims ratios? And why is this happening? We found that one of the states, given the high claims ratios, it disrupted scheme operations. The insurance company for some time stopped processing claims, and the scheme was affected. And so we try to look at why this was happening, because for a public scheme like this, you do expect utilization to be high, especially when there are a high volume of beneficiaries in the state. And what we saw is that the premiums that they had bid at, the premium rates that they were charging the government and that they had bid at were really low. They were lower than the benchmark premiums that were, initially actuarially set for this scheme by the center. And so this was obviously done so that they could win the contracts, but then this was not really panning out for them in the broader scheme of things. And so we asked insurance companies why they were doing this, and they said it was to win contracts, because in schemes like this, they don't make profits really from underwriting. Where they make their profits is from using these large premiums they get, because these are public sector schemes. There are high numbers of beneficiaries. So the lump sum premiums that they get help them make an investment profit, which is what they really value rather than underwriting profit. But this does disrupt the scheme sometimes, because when they have to report performance and they report such high claims ratios, it can adversely impact the scheme. Related to this, we also saw, how come the rejection rates were low? Remember, I said that the rejection rates in insurance states were lower. And this could really be explained by the payment terms. We see that, higher the claims ratio, higher is the administrative fee that they're allowed to retain. And so there was really no incentive for insurance companies to reject claims. Now, this is one could think initially that, oh, it's a good thing, they're not rejecting a lot of claims, but then are they really looking at whether these are genuine claims? Are they doing the audits and the fraud detection accurately? This is something that we could not really ascertain in the study, given the limitations of the data we had, but was a concern because there were low rejection rates, because there was no incentive really in their contract terms. They had performance indicators, but there was no way to really tell whether this was being done adequately. And then, of course, the performance indicators are important. We saw that in some states like Jammu and Kashmir, the state was overseeing this well. They intervened when they saw high claim rejection rates, and it really sort of reiterates the importance of that governance arrangement where you have a public entity overseeing the private entity to make sure that it's doing its job the way it was intended. And so really, our study shows us that one is in this particular example of private sector engagement, there is a limit to the engagement that the government sets. So it's for a limited set of purchasing actions, which are essentially claim and financial risk management. And through the contract terms, there is a limit placed on the profit-making potential as well as the loss-bearing risk of an insurance company. There were efficiency benefits, but this was, to the extent that they could process higher volumes of claims and reimburse claims faster with a smaller workforce. So there were some efficiency benefits in contracting insurance companies. We found that, of course, as you see, the contract terms are really important, not just having them in place, but having them monitored so that the insurance company does not unnecessarily reject claims. But we do require further study to see whether this is also able to, detect fraud well and the quality of the claim auditing that is done by the insurance companies. One of the concerns, as we saw, was that the perverse incentives that were being created for private insurers to offer really low premium rates. Now, this was impacting their ability to smoothly operate the scheme. And it does call, and this was an important policy implication that the National Health Authority was interested in, was that it was important for them to really work out, for states to, at their level, work out benchmarks and put these in maybe the technical criteria for selection of insurance company, actually determined premium rates that could help with selection of the appropriate insurance company. So I'll stop there and maybe any further clarifications during the Q&A. Thanks.
Thank you. Thank you very much, Prof. It's exciting to hear about the fact that insurance companies show higher efficiency. One thing that I took from your presentation has to do with the fact that once we are able to have standard treatment guidelines as well as capacity building, strengthening, we are able to reduce the number of rejections in terms of claims. Thank you very much. Our final presentation is going to be delivered by Dr. Christabel Abewe, Technical Officer, Health Financing from WHO Uganda. Christabel will be presenting on how public financing for not-for-profit private healthcare facilities is driving access and delivery in Uganda. Christabel, over to you.
Thank you so much, Kingsley, and good afternoon to colleagues in the room and colleagues online. It's also a pity that I can't be there physically, but we're happy to join the session. So like Kingsley mentioned, I'll present today on Uganda's case to exemplify how we've utilized public financing in our private not-for-profit health facilities as a tool to impact one, governance, but also service delivery output. I must lead with caution that this is exploratory research to get initial understanding on the topic, and it's not we've not had any like logistic regressions run to really prove correlation between the two. So just to contextualize Uganda for colleagues in this regard, so Uganda was one of the first sub-Saharan African countries to pass a public policy translated also to the health sector. And this specifically came with implementation guidelines for how the government can engage with private not-for-profit health facilities. And so in 2015, the PPP Act conferred authority to all government agencies to engage with the private sector to deliver goods and services on behalf of the government in various aspects of the economy, including health. And as a result, the government then put in place some required governance structures. For instance, a unit was set up at the Ministry of Finance to oversee all the PPP arrangements at the central level. But also for the Ministry of Health, we had the PPP for Health node, as well as the focal points, both at the district level and at national level, to effectively engage with the private sector. And really, for the health sector, this engagement to deal with the private, not-for-profit specifically, facilities, it came because of the recognition that the government cannot cover, it can't canvass all the places. And so there's places where, it's either hard to reach or the PNFP already has good grounding in the catchment area. And so the government decided to provide a financial subsidy through the primary healthcare grant. And this was, until last year, this was split, the total primary healthcare grant that's given to the private not-for-profit facilities is split in a way that 60% is an unconditional grant, which goes to supporting the operational costs of the facility, and then the 40% of that grant is tagged to a results-based financed conditional grant, which then links to a few quality and quantity output indicators. In addition to the PHC non-wage grant that the government gives as an incentive, they also provide to these PNFP hospitals and health centers a credit line for drugs and essential medicines. And if we look at the total government subsidy to these private not-for-profit facilities, 50% ideally should go to the drugs, the credit line for drugs, and then 50% for the primary healthcare grant. Lastly, in addition to these two grants, the government in the last 2 years, they've formalized a wage subvention for a few less than 10 of these private not-for-profit facilities to send over some seconded medical officers in some very hard to reach health facilities, but also facilities that are located in like game parks, where the government has no footprint at all in terms of health facilities, but the PNFPs already had facilities in there. So the government seconds medical officers to a few of these facilities to support as well. So in terms of how we've approached this exploratory research, one, we've conducted a desk-based review of which has been of qualitative research design. Of course, it has been also taking into consideration quantitative data inputs. And we've mostly collected this data from published Ministry of Health documentations like the annual performance reports, as well as some grey literature that we had access to. We were able to validate the findings from this study with key Ministry of Health officials in the budget and finance unit. So in terms of the results, we've seen is that the primary healthcare non-wage allocation to private not-for-profit health facilities has been growing over the last 4 financial years. And especially between the financial year 22-23 to 23-24, we saw about 12% increment in the allocation that the government was making to these sectors. And this is because that was the year that results-based financing was introduced. So we have 60% again of this grant is a non-conditional grant to support operations, but 40% is tagged to the results-based financing indicators. And then in terms of the credit line to the health facilities, again, we see a consistent, I mean, the first 3 years that you see on the slide, it's been just the same amount pretty much. But in the current financial year, we saw a big increment of 44% allocated specifically for drugs for the private not-for-profit hospital. This has really gone a long way in improving availability of drugs and reducing stockouts at these facilities. So in terms of uptake of services, utilization, this slide shows outpatient services. And on the left side of the graph, you have your outpatient for private not-for-profit facilities. We see that about 14% of the patients utilize these facilities for outpatient services. And on the other hand, we've contrasted this against the private facilities which do not receive a subsidy from the government. And we see that utilization of services here is quite low compared to the facilities in the same private sector that receive a subsidy. And again, just a little caution there is that the private for-profit facilities are not very good at reporting into the data system. So that could also be contributing to the discrepancy that we see. So in terms of the inpatient service utilization, we see the same trend. So we see that facilities that receive a subsidies from the government have a higher, almost double, twofold utilization rate as compared to the private for-profit facilities that do not receive a subsidy from the government. Okay, so what were the key messages that we found? First is that we found that this using of public financing for the private sector improves alignment of the private sector to what the government has identified as national priorities, because then the government is able to ensure that the activities which the PNFPs are undertaking are aligned to what they have prioritized both for the sector, but also for the national development plan. The second key message that's coming out strongly is that we've noted a consistently higher utilization of services in the facilities that receive this subsidy as compared to the ones that do not. Again, we've not performed a logistic regression to confirm that these two are indeed correlated. But from what we see now, we like to think that they are. And future research will prove some of the things that we are finding now. And the third point is that as a result of using this public finance to support, there are 545 PNFPs that receive this subsidy. There's been improved availability of essential drugs and medicines. And also it's really comforting to see that the allocation for the credit line is increasing. And between the last 2 data points that I showed, there's a 44% increment. And then lastly, because of the 40% PHC non-wage that's tagged to results-based financing, we believe that this public financing is going to work as a tool to improve quality in service delivery in the private sector, but also it's improving accountability in that sector as well as reporting. Because all these facilities are required to provide data into the government information systems. And we're seeing that there is better reporting from the facilities that receive this grant as compared to the private health facilities, which are also asked to report, but they're not motivated to, I suppose, because they don't have the same subsidy. So in conclusion, we've from this exploratory research, we found that to deliver on public health service provision, and on UHC and on health systems resilience, it's very critical to have a well-governed health system which incorporates both public and private actors so that they can all collectively deliver on common intermediate and final goals. And we've also noted from this exploratory research that using public financing as a tool for PNFPs, it has a potential to improve alignment of the private sector's behaviors, also to align their capacities and instruments to what is set out in the national health priorities. Third is that public financing to private not-for-profit health facilities in Uganda has been used to increase utilization of health services, public financing to PNFPs has also improved governance of the private sector, especially through strengthening oversight and accountability, and also reporting, as I had mentioned in my previous slide. And while all these things are great, we still have a big funding gap, because right now, the funding that the government is giving to the private not-for-profit facilities, while it's playing a critical role, it remains very insufficient. It's only covering 37% of the PNFP's need, and that leaves still a significant need of 63%, which is not being covered by the revenues that these particular facilities are generating. Thank you, and back to you.
Right. Thank you very much, Christabel. Can we give her a clap? Yes, thanks so much for sharing the benefits of using public financing for private for not-profit. Such arrangement is really beneficial to health outcomes, service delivery, and so on and so forth. At this point, we have about 15 minutes to close the session. So we just want to take clarifications from the audience. If you have any clarifying question from the audience based on all the three presentations we've had. Anyone? It means they did a good job. All right. So I'll come back to Dr. Kaya. I have a question for you. In the context of LMIS, what are some of the key considerations that determine the appropriateness of the implementation model to be selected?
Thanks, Kingsley. So yeah, I think, the important thing is, like we said, the decision to contract an insurance company or to purchase directly through the public entity is really one that states take based on their capacity. That's the first consideration that they usually make. Do they have the required institutional structures to purchase and to manage all of purchasing on their own, or do they need the additional resources that an insurance company can provide? And so the important thing to consider is when you for a scheme like PMJ, which is seen to be one of the primary vehicles for UHC in India, states should think about or need to be thinking about long-term institutional expertise for purchasing, because when you use contracted agencies, there could be a lot of attrition, there could be a lot of changes over time, and a lot of the expertise that is built then gets lost. And so that's one of the things that we talk to states about thinking, to think about, because even if they're doing it when they're doing it through the public trust, then at least there is a little bit more of institutional building that's happening, because they need not just strength in terms of numbers of human resources, but of course the technical skills for purchasing, besides, of course, benefit package design and payment design and things like that, but also in terms of managing claims, detecting fraud. All of these require a lot of skill building, and it really makes a difference when public entities themselves are able to build and retain these skills in the long term without too high a dependence on contractual staff. So one is to think about, and then so of course political will becomes extremely important here, whether states are willing to invest what is required in building those long-term resources or not, whether they're able to, of course, and where they're unable, of course, then the option of the insurance company exists. Now, another factor is cost. Now, we did try to look at costs, but we weren't able to get all of the data we needed to do a complete costing exercise. But based on what we did initially, we saw that usually the insurance model is the more expensive model. It does cost states more to contract an insurance company than to do it through their own resources. But when there is high efficiency, when there are high, this high utilization, then the cost per claim can be lower. So there were some states, like Meghalaya, for example, amongst our insurance states, that actually the cost per claim was much lower, although the overall cost for the state was high. So it depends on how you look at it. In a trust model, usually the administrative cost is much lower because they're running it through existing government resources, but they do contract a lot of staff as well. They're also given a lot of support from external development agencies that provide their own staff for certain, technical functions. So these are the different considerations. Both, do they have the capacity and do they have the financial resources for either model? So I would say that those are some of the key considerations that that states need to keep in mind. But just to add that if they go for the insurance model, which can work, we've seen it has its benefits as well. The governance part is super important to make sure that they align with with the objectives of the scheme. It really becomes important for the public entity, the state health authority, to still be very much involved in the day-to-day purchasing and oversee the contract terms of the insurance company.
Thank you. Thank you very much. Once again, the issue of data availability or unavailability has come to the fore. And I think that's something that going forward, we need to work towards that. So I think I have one question from the audience. So I'll take that before coming back to the presenters.
Okay, thank you. So I have a question for Christabel and Elizabeth from Uganda. So thank you for the presentation. We've certainly seen that there are benefits in government supporting the private not-for-profit sector. And from what you presented, we could see that this is being missed in the private for-profit sector. So I wanted to find out, in your opinion, do you think government needs to also think of moving towards supporting the private for-profit sector, particularly perhaps in urban centers where you find that, in a place like Kampala, the urban population is so huge and the number of public facilities and the PNFP facilities do not match the need. And then secondly, how can government improve its oversight and contracting capacities? If it's to contract the private sector, it needs to improve on that. How do you think they can be able to improve on that? Thank you.
Thank you very much, Elizabeth. And so, Christabel, the issue about delivery strategy, governance arrangements around the contracting, you want to take that?
Yes, thank you, Elizabeth. And it's nice to have her in the room. She could even actually add more to the question that she raised. So in terms of engaging private sector, I believe that there's room for the government to engage with the private for-profit, especially in the urban centers and also in the hard to reach. But of course, without these pieces of evidence, which illustrate how far government's use of public resources as a tool to advance quality, to advance governance, to advance better partnership and alignment, it's very hard to make the case. So we are starting to see the need. And I think one thing I didn't really speak about was also in the price negotiation. In the private not-for-profit facilities, as a result of these subsidies, the government has been able to set together with the faith-based umbrella agencies some price ceilings to the services they provide. And we're starting to see that in the private for-profit, especially during COVID and in other emergency situations, the private for-profit tends to take advantage of clientele because they're in an emergency and a crisis situation, and so there was poor regulation in pricing in that sector, and so the government definitely needs to come in, and the strongest tool that the government can employ is money to have this sector better regulated, because it's harder to enforce some of the softer power tools if you're not giving people some money. But once you give them some money, it becomes you then have a strong lever to use for enforcement. So certainly these are conversations that need to be had. I think the challenge that there is still very inadequate resources, even for the public facilities. It challenges the motive and the good intention of the government to really go into the private sector. Because as they say, charity begins at home. In the public sector, there's still not enough money. And so it becomes really difficult for them to spread themselves quite thin. But I think a strong case can be made, especially when we analyze utilization patterns in the urban centers and in the urban districts, where most of the facilities that people go to are actually private for-profit. We just really need to put a very compelling case together. And I think the Ministry of Health is a very listening agency, and this is something that they would be able to take on. In terms of improving capacity to contract, I know that the HIV programming, before all these budget cuts, they've been trying to consider some private contracting with the private facilities, specifically for HIV programming. I don't know how that has now been affected by the budget cuts and the stop work orders, but I can't remember if it was in the session yesterday. I think some of the colleagues from Lesotho and other regions, they were speaking about the need to first build capacity and understand from other places what the best practice is on this private contracting, because I believe in some places, I think in Southern Africa, it has driven up the cost of engaging actually with the private sector. So we need to approach this from a place of knowledge, from a place of understanding what's working in other places. But I believe there's potential for it, and we had HIV/AIDS as an entry point to start considering private contracting.
Thank you. Thank you very much, Christabel. So we'll ask the last question. Malik, I just want to find out, given the given pricing remains as one of the most contentious issues determining private sector participation, what steps has India taken, if any, to arrive at a consensus regarding this matter?
Thank you for the question. I think so. The price point was and still is a concern. So let me say that the resolution, the government did take some stand, but it's still not a resolved issue. So initially, when the hospitals or the private sector got engaged with PMJ, the reimbursement rates were pretty low. 2 years back, government again went through whole this health benefit package redesign exercise, and they increased the reimbursement rates of around 1,200 packages. Now, so that obviously the delta got changed. Now, whether the delta change is acceptable to private sector is something that we'll see. It's too early to take a comment on that, because even after the revision, again, as I said, that PMJ is designed at a federal level and implemented at the state level. So federal level guidance is not uniformly implemented at a state level or a provincial level. So the bone of contention still remains in terms of the reimbursement of benefit package that are currently offered. That's one thing. Second thing, even the depth of benefit package is also an important element, that what is covered as part of benefit package. Now, currently, let's say after an inpatient episode, five days or 7 days of home-based care or medication are supported. But there are instances where this needs an extended effort or extended intervention is required, and those are not covered. So the design element is still something which is unresolved, and with states under fiscal pressure and the fiscal deficit increasing day by day, with the economic shocks that everyone is kind of absorbing, I don't know how states are going to respond to kind of redesigning benefit package so soon. So even though the effort have gone in terms of relooking at benefit package in terms of depth, in terms of value, in terms of differentials, in terms of tier one reimbursement rates are very too different from the metros to big cities. Those rate differentials have been kind of brought into kind of design elements. Implementation is something that we will see over a period of time, how it really strengthens private sector involvement in PMJ. Thank you.
Thank you. Thank you very much, Malik. So we'll just invite Brendan Kwesiga from UNICEF to give us reflections. Yeah, to give us reflections on the three presentations. And then after that, we'll get the closing comments from Dr. Grace, just to bring the session to a close.
Thanks, Kingsley. This is Brendan. You've been called Brendan by the previous presenters. So I think, to me, we had a very useful session showing us what has been done in the two countries, what's working and what needs to be improved. I think one broad reflection that is cross-cutting across the three presentations is the importance of institutional frameworks. I think when you reflect on the governance behaviors for engaging the private sector, it's important to have a framework in which you're engaging. The example from Kaya's presentation around the contracts as a tool for shaping incentives, but also, if you remember the Uganda story about defining some of the specifics for which your money should buy, I think are critical. So one very important thing emphasized around governance actions by the three presenters is the role of institutional frameworks. And linked to that is having some clear metrics to know when things are working. I think the question asked by Elizabeth, but also some of the work I was presenting around the comparison between the trust-based and the direct insurance procurement purchasing emphasize why you need to have a mechanism of continuous learning as you engage with the private sector, which also I think is an important governance behavior for engaging the private sector. So clear institutional frameworks, keep learning and keep generating knowledge to learn so that you can do some improvements. The third bit, which is very important to emphasize, and I wish I had mentioned it first, is the role of public stewardship and ensuring that there's strong capacity by the public sector for you to engage with the private sector. Oftentimes, and I know colleagues in the room know that for private sector to engage, for them, their incentives are clear. Private sector is driven by profit. So yes, the institutional framework, such as the contracting, may help you shape and moderate the incentives and moderate how they behave. But then you have to have strong stewardship and strong capacity to enforce to ensure that you get the results that you want. And again, I think that interrelationship within the states in India where they are trying to manage the claim rejections is a good example of why you have to make sure that the public sector capacity is strong even when you're engaging within the private sector. I think to conclude, one exciting thing is also, as I said, although we know contracts are tools to shape incentives, oftentimes you may see some counterintuitive action by the private sector. And the examples Kaya shared also, I think, were interesting, but also some of the structural failures Malik shared also point to some of that. So given those counterintuitive reactions, or for instance, for where we expected the private sector to be having high rejection rates, but then they have an incentive not to reject, it's important for the public sector to structure reactions, to structure actions that are able to shape some of that. So to me, I think this discussion emphasizes some of the governance behaviors that we need to strengthen as countries. Even the presentations themselves, and I know Christabel talked about what this learning can be used to. So the presentations themselves emphasize the need for us to ensure that we create a learning environment to shape how we work with the private sector, to have institutional mechanisms of engaging. I know in one of the stories, I think in Uganda, as they were finding the engagement with PNFPs, the private not-for-profit, previously the engagement was based on a memorandum of understanding, but now because of strengthening institutional frameworks, it is through contracts, and which has to be approved by as high as the Attorney General. So the importance of contracting then ensures that you have capacities both on the public sector side, but also on the private sector side. The last bit is issue of quality. I know cost is an issue and we easily monitor costs, but ensuring that quality is also emphasized should be one of the things which I think also came across in some of the presentations. So as I conclude, I would like to thank the presenters. I think the lessons from PMJ, which is the largest insurance scheme, were enlightening. I know there are countries in the room. We have people in the room who also are supporting countries on these insurance discussions. So that's very important for us to take home. Thanks very much, the presenters, and I hand over back to Kingsley. Over.
Thank you. Thank you very much, Brendan. So at this point, we will just close the session with a wrap up from Dr. Grace. Grace, are you online?
Yes, I am.
Yes. So take us to the final conclusion.
Yeah, thank you very much, everyone who has attended, but also who has contributed by way of discussion. I think I would really echo Brendan's sentiments on the need for institutional frameworks, particularly contract management. I think it goes a long way in managing behavior, but I think it should go both ways. I think within the PPP arrangement, trust is a key issue, and it should be enforced or backed up by action on either side. And so as you can see, Malik's presentation, but also Christabel's presentation touched a little bit on it. You're contracting these entities, but if payments are delayed or the money is not as forthcoming as it should, you're not meeting the end of the bargain as a public partner. So that is something that needs to be really reinforced. But also, it's not just about the service provision. At the end of the day, it is the beneficiary who is affected, because with some of the cases we see a bit of balance billing when, for example, payments are delayed, or in some cases double billing, and the patients are the ones who are bearing the brunt. So the schemes don't benefit in terms of the goals they are pushing for, but also the patients are suffering in terms of financial hardship. The issue of quality of care is important, and I just want to point to the India perspective. I think India has gone a long way in including the standard treatment guidelines as an adjudication feature. But largely at the moment, what we see, it's more around claims adjudication. It's not being enforced for purposes of improving quality of care. And that some of these are design elements, but also implementation elements. And so really how to get that is the next step of the conversation. I think for all, in a nutshell, what these three case studies show is that design is not the only factor. I think the fidelity to implementation is important. And so how both parties engage in that is something that really constantly needs to be reviewed, constantly needs to be reinforced. The Ugandan case study is an interesting one. I've also worked in that context as well. And it's interesting to see the evolution of the relationship between the government and the PNFP. At the time I worked there, that money had more or less leveled, but now you can see some leaps and changes in the discussion in a manner that is beneficial, not for only the PNFPs, but also for the government's objectives. So I think a need for constant review and learning, as Brendan has said. With that, Kingsley, I just want to reiterate the thanks for everyone who has been involved in putting this together, and wish all a good day.
All right. Thank you very much. Thank you. So a big thank you to all of you. We just moved to the next session, and I'm still moderating the next session.
Bye-bye, Kingsley. Thank you.
Bye-bye. Thank you very much.
Bye, everyone.
Thank you. Bye.
Bye, thanks.
Right. Do you have the presentations? Which one?
For the next session or
The session.
the one for which hour?
11:30.
I have one session, I have one presentation. All the other three give.
Maybe.
One guy gives me one presentation.
Okay.
This one.
All right. Hello, Helen.
Yeah. Good morning, everyone. Good morning.
Good morning.
Kingsley.
Apologies. We couldn't finish the plenary per the timetable, and so it shifted the whole schedule by 15 minutes. So I think people are getting in now. The
Okay.
next 2 minutes, we'll just start our session.
Excellent.
Apologies for keeping you waiting.
No, that's fine. And I think Moritz is also connected, so we're good.
Hi, yeah, I'm also connected. Do
Thank
we
you.
pull up
Thank
the PowerPoint on our end, or will someone do that on our behalf?
I think you can control from your end. I think that would be easier. The first presenter. Okay. Oh, you start. Yeah. Yeah. Really?
Kingsley?
Hi, Maurice.
Hi, can you confirm that I have the right setting to share a slide? Because I can't see the option here unless I'm missing it somewhere.
Okay.
Yeah.
And he's
Helen, do you have the possibility?
Helen, are you able to share your presentation? Otherwise, we can do it from here. Don't worry.
Actually, I don't have a presentation because I'm just a discussant, but it seems that I have the rights to do it. So then Moritz should be allowed to share his own screen as well.
I don't see the option anywhere. I'll reconnect. Let me
You don't
try
have
again.
the share button, the green share button?
Yeah, I don't see it. I'll try and connect from your link and see if that makes a difference.
Okay.
Maybe is it possible to start with the Moritz one? Yeah. Okay.
Is it working, Moritz?
Right. Good morning, colleagues. Once again, we are going to start our next session. Just as you're aware, there is a growing interest and awareness of the potential positive relationship between public financial management and health outcomes. Broadly, PFM has long been accepted as critical to strengthening allocative and operational efficiency. Building on this, the theoretical assumption then argues that strengthened PFM systems influence how and what funds are allocated to health sector priorities, which subsequently impacts the quality and access to health services. As a result, more people have access to improved services without exposing them to financial hardship, subsequently improving health outcomes. However, upon further examination, while the theoretical, explicit, and implicit foundations are there, little empirical evidence has been generated to unpack the link between the two. In this particular session, we are going to have two presentations. The first one will be delivered by Moritz, who is a senior economist at the World Bank, working at the nexus of public health and health, public finance and health. He's interested in how public financial management reforms can be enabling force for efficient and equitable service delivery. His work is currently focused on reforms in the African region, where he leads various analytical programs that include how to deploy disruptive technology solutions. During his time at the World Bank's Independent Evaluation Group, Moritz led various evaluations of World Bank support to public financial management reforms and has written extensively on what makes financial management information system effective. Our first presentation will be looking at funding to health services, PFM, a pathway to reach 1.5 billion. Moritz, it's your time to share your experience with the audience. Thank you very much.
Thanks so much. Can you hear me okay?
Yes, quite audible.
Thanks. And would you mind managing the slides from your end, because I don't seem to be able to do it from. Oh wait, let me see. Let me see it. I was able to share a request. Otherwise, we can just move along if that's easier.
We are moving for you.
Okay, so then thanks so much. Thanks so much, everybody. Great to join in virtually. It was good to see everyone in person the last couple of days. Yeah, so we have started doing this work, started exploring this already in 2016, 2017, where we were looking at the relationship of the strength of PFM systems proxied by the PIFA scores and various outcome indicators, right? And we found a pretty strong correlation. And since then, there have been kind of a number of other studies looking at different, slightly different things, and that's been useful. And it's great to see how many things are coming together. Now there's been a corporate commitment by the World Bank to reach 1.5 billion. So that there's this target. So we asked ourselves, what would it take? Right? And to what extent can public financial management systems contribute to that? And can we establish a close link, right? So that we can say, we contribute in a very specific manner. And the other thing that we wanted to do is bring it closer to the output level, right? So looked at before was under 5 mortality, and we looked at maternal mortality. And so we looked pretty far along the outcome chain. Next slide, please. Yeah. And so, then we're in the, right, from a conceptual framework perspective, and we wanted to look specifically at how the PFM system, right, and through the various aspects of the PFM system produce services, and then separately look at how the services that have been produced then contribute to health, right? So, and some of the studies, if you move on to the next slide, right, have looked at the far end of this logic, right? So directly from the PFM system to the health outcomes. Okay, so then if you move on to the next slide on data and methods, right? So what we're saying is really, right, how does the PFM system affect service coverage and UHC, right? And what is it that we're measuring here, and how does this relate to the goal of the 1.5 billion? And then, right, how does that relate to health outcomes, right? And there are several studies looking at that. So we had a very specific objective in mind, right? So and now that kind of quite a few years have also passed since we were first looking at this, we have more countries, right? We have a longer time span. We have access to more PIFA assessments, which means we also have more variability within that, right? And the variable of interest then specifically was the PIFA scores, and we translated the scores from which we have from an A to D index to a numerical one, so we could run the regressions. And the outcome variables specifically, or right on the left-hand side, where the UHC coverage index, DPT and measles immunization coverage rates, HIV ART coverage, ANC4 visits, and vitamin A coverage. And specifically, the econometric strategy was that we use country and year fixed effects wherever that was possible, and it wasn't always possible. And we used random effects when too few observations would have rendered the fixed effects regression unfeasible. And we've controlled for a number of factors, including GDP per capita and current health expenditure as a share of GDP. And just to also say that we've run a set of robustness checks. So we've looked at CPIA, and we ran the model with various lags and so forth. And generally, the robustness checks all turned out to be reasonable. So then, with regards to our results, we do find it positive results, and even though that result here is a bit weaker than what we found when in our first paper in 2017, we do still find that a 1 unit increase in PFM quality is associated with a 7.6 point increase or 13% increase in the service coverage index of UHC, right? And that's pretty significant, right? That's a pretty significant number. The number of countries that we were able to run this on was 61, and we had 76 observations in this. So for this specifically, we had to use random effects because we didn't have enough observations for fixed effects. However, for the DPT, measles, and HIV coverage, we were able to use fixed effects, right? And while for DPT coverage, we didn't find a statistically significant relationship, we did find that for measles coverage and HIV. Next slide, please. Thank you. So what this, right, when one maps that out, right, in terms of the gains that show up in this model, is that the increase in children 12 to 23 months immunized would be about 4.5 million per year, right, from a 1 unit increase in PFA. The increase in children immunized with measles would be about 7 million. The service coverage index improvement is 13%. As I said already, it's difficult, right, to say how many people you would reach, given that it's a unitless index. And the increase in people living with HIV would be about 3 million per year, right? So big numbers, and a pretty significant effect, and it would indicate progress towards our corporate goal of 1.5 billion. And then if we move on to the next slide, where we're showing some robustness checks, and perhaps if there are questions on the robustness checks, perhaps I can go into them during questions to save on some time now. But just to point that out here briefly. But and let me just move on to the last slide. So, right, we are making the case that PFM is a pathway towards our corporate target of 1.5 billion, right? And strengthening PFM systems and specifically adjusting these to health sector needs has a significant positive effect, or appears to, and this result is valid for most service coverage indicators that we looked at, and it is also robust. And the only caution that we'd like to make is then that also PFM can mean a lot of things, right? And we looked at a very generic indicator with PIFA scores. So, you know, one could look at the various sub-indicators. We didn't want to do that because you lose a lot of the variation in the data, right? And you know, we lost a lot of the predicting power in our models. And similarly, when we looked at specific sub-regions, we lost a lot of the predictive power of the model. So we didn't do that either. The last thing that I wanted to say is that it's been quite difficult to identify an instrument. We've tried a few, but we've only made it halfway there. Right. So if there are any suggestions from the room, that would be fantastic. So, for example, one of the things that we looked at was whether there was an IMF program or World Bank engagement, and how extensive the World Bank engagement was on strengthening PFM systems, but there was no specific health engagement, right? So then that way you lose the, so that way we established a correlation to the PIFA scores, but not to health, right? But we weren't able to get the sign or the statistical significance where we wanted it to, right? Yeah, so overall, I mean, there is still quite a bit of work to be done. It's great to see that so many different pieces are coming together. We're trying to make a corporate case that investing in PFM does make a difference. And right, and what we do know is that, you know, even though PIFA scores are pretty broad way of looking at PFM, that is making a difference, right? Then when one, right, which is indicative that when one looks at specific indicators that are more relatable to what we're looking at in health financing, right? Things relating to autonomy, things relating to purchaser capacity, and so forth. One would imagine that the relationship would be much stronger still, but there are no specific indicators there to look at. So with that, let me pass it back over to you, Chair, and thanks so much again for inviting us.
Thank you very much, Maurice, for sharing your experience on the positive correlation between PFM and UHC and health outcomes. So we will invite our next presenter in the person of Jan Tapsoba, who is with the what's the name of the organization? Sorry, Financing Alliance for Health. And his paper is looking at, does public financial management save life? Evidence from a quantitative review of PFM and health outcomes in sub-Saharan African countries. All right.
Good morning, everyone. Welcome. English. Thank you, Kingsley, for giving me the floor to present this paper, which talking about the public financial management effect on health status in sub-Saharan African countries. This paper was published in the Journal of Health System and Reform, and it was co-written with Hélène Baroa, Kingsley, and Amna Selim. Slide, please. Okay, this slide provides a context and the rationale that has justified our idea to work on this topic. We can observe that the sub-Saharan African region, compared to the others, record the lowest government spending on health from domestic sources. And we can also observe that the quality of PFM in sub-Saharan African countries remains lower compared to the other regions. And in this way, we have to say, okay, it is necessary for our countries to increase the resource mobilization for health, but the most thing that we have to keep in our mind is how to find the best option to improve the use and the management of these resources. And in this background, we developed a conceptual framework to which the public financial management have to impact the health improvement to health services provision strengthening. The first, we have 3 PFM functions: the budget formulation, the budget execution, and the budget oversight. For the budget formulation, the policymakers generally decide on how and where the spending have to be spent. And a budget which is formulated in line with the sector priorities, a budget which is flexible could improve the effectiveness of spending and then increase the healthcare provision and then improve the health outcomes. In the side of the budget execution, the process and the rules in the budget execution is very important. This process has to allow for dispersing the resources timely and fully, and this could improve the planning of spending and then increase the healthcare provision and health outcomes. For the budget monitoring, the budget oversight, it's important to promote the transparency and accountability that could help to increase the healthcare provision and the health outcomes. This paper focuses on 42 sub-Saharan African countries over 2018. In this paper, I would like to precise that we estimated correlation effects and not causality effects because of the data availability that was not covered over a sufficient time series. We estimate 2 kinds of correlation effects. The first is the PFM effect on health outcomes, and the second is the PFM effect on health outcomes, but depending on 2 key drivers, like the budget prioritization for health and the institutional quality. Three health outcomes: maternal mortality ratio, under 5 mortality, NCD death rate. The PFM quality was proxied to the PFR rating, which were converted into quantitative scores, and we controlled the model for the GDP per capita, and the other variable that was accounting for is the health budget share and the government ineffectiveness. This slide shows the negative correlation between the PFA score and the maternal and under 5 mortality rate. But it seems that the correlation between the PFA score and the NCD death rate seems to be unclear. But let's start to investigate to the econometric model to confirm if there is or not a relationship between the PFA score and the NCD mortality rate. In this, we can remark that we have negative and significant coefficients between in the model, and this confirms that PFM quality is negatively correlated to the maternal mortality, under 5 mortality, and NCD mortality. In other terms, we can say that better PFM quality in a country is associated with lower maternal, under 5 ANCT mortality, right? In a second model, we focused on PFM subdimensions. And we can remark that the major part of PFM subdimension are negatively correlated to the mortality indicators. And we can remark that the predictability and the control in the budget execution is associated with the highest coefficient. And now we split our sample based on the median values on the health budget share. And we observed that the correlation between PFM quality and mortality indicators are significant and negative in a country with higher prioritization for health. But we can also observe that the coefficient do not be significant in the country with lower prioritization for health. We use the same approach, but now we focus on the government effectiveness. We find that the correlation between the PFM quality and the maternal and under 5 mortality is significant in the country with lower government ineffectiveness. In other terms, this correlation is significant in the country with higher government effectiveness. 4 items of discussion. The first is higher quality PFM with high-level political commitment, backed by budget allocation, contribute to health improvement. It's very important to implement length and complex reform to strengthen the PFM. Second, we remark that the budget execution are the highest correlation with the mortality indicators. And this suggests to improve the effectiveness and the regularity of the budget. It will be important to understand the cause that drive the low budget execution in the health sector. 3, we observed that the positive correlation between the PFM and the health outcomes is only significant in the country that provide greater prioritization for the sector. And this suggests to complement the PFM policies with the adequate and relevant budget allocation for health. The last point that I have to flag in this session is the role of governance, the influence of governance on the PFM effect on health outcome. It's very important to think about how we can strengthen the PFM, but this kind of policy have to be complemented by the political economic studies. Thank you so much for this time, and give you the floor, Kingsley.
Thank you very much, Jan. So these are the 2 presentations speaking to the relationship between PFM and health outcomes and generally UHC. Before I bring Helen to give technical reflections, I just want to get some clarifying questions from audience based on the two presentations? If there's any, yes, I have two hands here. Oh, there's one here, okay.
Thanks for the presentations. Just a question, because as I think Moritz mentioned, measurement issues are really important here, and especially, you know, PIFA and governance indices. A lot of these are arts rather than kind of hard objective criteria. To Jan on his presentation, when he presented the interaction effects with domestic prioritization and governance, you seem to have that categorized into higher and lower. Can I just ask how you treated that? Were you effectively treating these as dummy variables, depending on whether a government was across a threshold in that, or were you treating those as continuous variables? And a related question to Moritz, can you talk about if you controlled for the general quality of governance in the regressions as well? Because one concern is that if PIFA or measures of PFM are very closely correlated with general measures of governance, are we sure that we're picking up the distinct effect of PFM on this, or are we actually just picking up that, you know, spending tends to be more effective in countries with just generally better levels of governance? So thank you.
Thank you very much. Brendan?
Thanks very much, Moritz and Jan. I think I'm following on to Tom's question and linked. I know Maurice said he couldn't go through the robustness tests, but I think we can address some of them in the questions now. So given the potential methodological challenge of omitted variable bias, I was inquiring, I think, from both whether there was an option of testing any coefficient stability methods to address that omitted variable bias. Because I know, and your title, Moritz, was very, shows a lot of aspiration, and most times now we're required to make strong statements of what PFM can deliver. But we need to try and address some of the methodological issues, and I think it's a good platform to discuss. Thanks.
Right. So the issue of robustness has come. Yes, let me take one from here, and then I'll come back to you, Maria.
I think my question partly has been asked by Tom here. Oh, my name is Newton Chagoma. Yeah, so part of my question has been asked by Tom, looking at what threshold was used to divide or categorize the prioritization across countries, and did that differ from country to country? Just some awareness on that. And also related to that, did you probably try to tag the prioritization to what is the regional commitments, like say the Abuja or whatever might be relevant to countries in terms of financing health, just more broadly? And the second question is on the outputs. Looking at the results that you showed, the standard errors are a bit huge in some cases. So wondering probably maybe it could be down to the sample size as being so small. And also that again relates to what Brendan had asked in terms of trying to bridge in the methodological gaps. Like, did you think of alternative methods, like maybe using the lasso regression in that aspect to see what sort of outcomes, how the methods compare, the outputs compare using two different methods? Thank you.
Yeah, still on the issue of methodology, Maria.
Thank you. I have just a quick maybe question and reflection for Moritz. I was wondering if you had any thoughts about the difference across the health service indicator that you observed. Do you have any thoughts on why vaccination seems to have the kind of weaker effects compared to the UHC coverage index? And one of the thoughts I had is that vaccination in many countries is done in a parallel way somehow, both for procurement and also the distribution for campaigns. So I was wondering if that has any effect, or you were able to control for that. Thank you.
The effect of delivery models, vaccination delivery models, giving a weaker effect. So, Maurice, do you want to take that first? you want to pick it up from here, and then I'll come back to the whole.
Yeah, sure. So on the various indicators, yeah, I mean there are hypotheses that one can run, right, and one can think through, and I think, right, so this is one of the factors. Certainly is going to be to what extent partners finance some of these interventions outside of the budget, and thereby PFM is going to have less of an impact. Right. So one thing that one could do, and what we were considering or we looked into, is to only look at these factors in countries where more aid was on budget, but that reduced our sample size to the extent that we weren't able to come out with a clear message. So I think that has something to do with it, but yeah, it's a very legitimate question. So I really appreciate that. If you want me to go into some of the other questions, or Jan, do you want to come in at this point?
Robustness, yeah.
So on the omitted variable bias, and kind of, we're not, so we're not trying to make the case for causality, right? We're saying we have a corporate goal, and what we're trying to say is what's the relationship, and it's. Right. When one does research, it's always, and of course, one wants to get the strongest model in place possible, and one wants to be able to make a credible case for impact, right? And it's difficult to get at impact, and especially when one looks at institutional type studies. So where it's difficult to find a natural model that lends itself to any randomization, right? So here we're looking at I mean, one thing that one could do potentially is look at if there was a big bang PFM reform, and one would look at, okay, what happened before, what happened after, how effective was that reform, and what is it that the reform tried to do. But again, then you're only looking at things in one country, and so we've tried to explore that a bit, but so far we haven't come to, we haven't been able to point our fingers to anything in specific. So really the only thing that we have at our disposal at the moment is the cross-country regression. We have a reasonable number of countries, I would say a reasonable number of observations, and reasonable variability within the data, right? So that leads us to some to statistical significance, and with regards to the omitted variable bias, we also do have high R-squared values. So our model explains a significant amount of the overall picture, right? I would have to kind of go back into the results to pull out what exactly they were, and I can share that afterwards if that is of interest, right? But yeah, so I mean, I appreciate it. We don't have, we can't talk about impact, but but it is important that at some point that we can say that these types of reforms make a difference somewhere and somehow, so that you can join the conversation around what it is that this community does, right, and how it relates to very specific outcome related measures, right? Because that's what people are asking for, right? People are asking for, how many people did you touch, right, with the services that were delivered, right? How many people were vaccinated? How many under 5 deaths were prevented, right? And you can, if you're competing in a space where you say, right, where you look at a very specific intervention, right, and you can study with all of the econometric rigor that the world has to offer, right, because because that's available to you, then you're always going to lose out, right, because you'll never be able to make the case, and there's an imbalance there, right. And because then you'll always only be able to say, look, here is the very specific intervention that we should do in order to improve malnutrition, right? Or to improve something that's more specific than what you can look at when you look at a broader system-wide reform. Yeah, but back over to you, Chair. I can also get at kind of Tom's message, Tom's questions later, but perhaps good to hear from Jan.
Thank you very much. We'll take a few reflections from Jan, and then we'll come back to you.
Thank you so much. Just a reply to the question which was asked to me about the strategy that was used to analyze the role of, I think, the quality, the institutional quality on the PFM effects on health outcomes. We use the governance effectiveness effect, but in the model, this variable was correlated with the PFM scores. And in this way, we did not have this possibility to use the iterative variable in our model. In this way, we plan to divide our sample based on the median value of the index. And we regress, we make the regression in the two subsample in order to check if the this coefficient of this level of significance will change or not in the two subsample. Thank you.
Thank you very much. Maurice, do you have any additional comments? Otherwise, we'll go back to Helen on the technical reflections.
Tom, your question was about broader governance indicators, right?
Yes.
Yeah. So we did look at that, but we in a previous paper as well as in this paper, to both in terms of robustness tests as well as including it within the model. So we had various iterations of what we were looking at, and we're kind of very cognizant that a lot might get missed. And we looked at specifically the CPIA indicators but there is going to be a lot of overlap, right? Between the CPIA and PIFA, and then the risk is that you're introducing a lot of noise into the model. Thanks.
All right. Thank you very much. So at this point, I'm going to invite Helen Barrow to provide some technical reflections based on the two presentations. Helen, over to you.
Yeah, sure. Thanks, Kingsley, and thanks a lot to the presenters. So yeah, I'm very happy to share some thoughts. I don't know whether they would be very technical, but maybe some broad reflections on this research. So the first point that seems very relevant to me is the following. I think we really need this type of research, this type of evidence. I think there is a lot of global demand, regional demand, country demand for it. It's really a new body of research, and it's really great to see it coming together. So, but yeah, this first point really to appreciate and probably to highlight the rationale why we need it, right? And I think we need this type of research because there is still a need to make a strong case vis-a-vis governments, vis-a-vis country leadership, to put much more emphasis on PFM strengthening, to invest more in PFM systems, rules, and processes. And I think this type of research that was presented this morning really provides a strong rationale. Very much appreciate the fact that here we're not to provide a causal relation, but still I think it provides a strong basis, a very good value to inform future investment in that policy space. So it's very timely, very relevant, especially from a sectoral perspective. I think this is really great. The point that I just want to add in this respect is that I think that in the current context of freezing aid or declining aid, I was a little bit hesitant about the right word to use, but you get the point in this context where there is probably a need for even more public investment and a need for more public spending. It's very clear that PFM is really at the core. And so this is where I see that this research is really relevant and absolutely timely. Beyond that, the second point which is probably more technical, but I wanted to make is that I think we need much more disaggregated work. What do I mean by that? I think what policymakers need is really to get an understanding of the key dimensions, features, characteristics of PFM systems that do really matter most, and that do really matter most from a sectoral perspective. So I was very interested in seeing how Jan was able actually to disaggregate by different features or different dimensions of PFM systems using the PIFA framework. And then it shows that budget execution is actually one of the highest scores, right? So one of the key or the most relevant drivers for improving outcomes. So I think we really need more research on that to provide a much more granular and much more detailed understanding of the interactions between PFM systems and health systems outputs and outcomes. In relation to that, I had also on my notes a kind of caution note in terms of the measurement question. It seems to me that there are different aspects that would require also further work. Very much agree on the fact that PIFA scores, there's a lot of subjectivities in those, right? The way they are assessed. I think it requires further thinking. There is also issues in terms of sample size, the regularity or the non-regularity with which those assessments are done in countries, and also just to recognize the lack of data for certain aspects of PFM and things that are not necessarily covered in a very systematic way by PIFA frameworks. So all of that, I think, require really more work and potentially some rethinking on how we best approach PFM system quality as a whole. Last point that I wanted to make, Kinsley, is that I do think, as I said, that we need more quantitative research. This is a new body of research. This is much needed. But at the same time, I think we should not ignore the fact that we also need much more qualitative research in that space, right? PFM discussions in health systems or within the broader health financing context is still relatively new, right? We've been all, and I think I see some familiar faces in the room. I mean, several of us have been working on this territory for 10, 15 years now, if not more. But it seems to me that there is still quite a lot of qualitative things that also need to be further defined. What do I mean here is that it seems to me that there is still a lack of understanding of the key kind of desirable attributes of PFM systems that do really matter to drive health system reforms and to drive progress towards universal health coverage. So we've been discussing a lot about making the case for PFM, but I think we need to much more systematically identify and formalize what are really the key directions. What do we need? What what is needed from a PFM perspective to drive progress towards universal health coverage. There has been some recent work on provider autonomy, on budget structure, on budget execution, but I think now is the time really to formalize and systematize the evidence and really to provide much more clearer, explicit guidance to government, to countries in terms of the key ingredients that do really matter from a qualitative perspective. So what needs really to be adjusted, but really to do that in a much more systematic way. I'll stop there. Thanks again for having me. And I really enjoyed the session, even though I was not physically.
Let's clap for Helen. Thank you very much. So we've come to the end of the session for this afternoon. We pretty much looked at the impact of public financial management on health outcomes, what the evidence is saying. And I take two main points out of the discussion. The first point is that we need to develop a context-appropriate response to PFM challenges. It's critical and requires further qualitative work in countries. And I think that's something that for the research world, academia, to pick it up. Policymakers and teams should consider PFM in health systems strengthening efforts. So in terms of donor priorities, we need to look at how to strengthen PFM in countries. And then the final point is to maximize the PFM's utility in achieving more favorable health outcomes. There is a clear value, as demonstrated quantitatively, in studying PFM and political economy factors, which is also linking up to the qualitative aspect of it jointly, just to bring the two together, just to ensure that particularly environments where we are facing challenges of governance. If remember, we try to look at the governance element to test and so on and so forth. So at this point, we'd like to say a very big thank you for sharing your time with us. And I'm sure this is just the beginning of our discussions and conversations. Thank you very much for your time.
Thanks for inviting us.
All right. Thank you, Maurice. Thank you, Helen. Thank you. Maybe I think it's time for lunch. Unless maybe you are fasting.